that led to the recent publication and the presentation, late-breaking trial in the recent European Society of Cardiology. It was last week. They presented and published in the New England Journal of Medicine the EMPEROR-reduced trial with the empagliflozin in patients with heart failure, the HREF group, heart failure reduced ejection fraction. The patient had EF less than 40% with elevated NT-proBNP, with chronic heart failure with NYHA class 2 to 4. They can be either type 2 diabetes and non-type 2 diabetes, and they are on standard of care, and some of them on the device therapy. And they evaluated the 3-point MACE. The primary endpoint was adjudicated CV death or hospitalization for hospitalization, which was shown beneficial. The key secondary endpoint, which were first and recurrent hospital hospitalization, also being confirmed positive. And the key secondary endpoint, the eGFR slope, which is how bad worsening of the kidney, also shown beneficial. So if you look at the primary endpoint, the first adjudicated CV death and or hospitalization for heart failure, there's a relative reduction of 25%. The graph split very early, sustained split throughout the course of the trial with the absolute reduction of about 5.2%. The number need to treat was very low, only 19 patients. And the beneficial effect is conferred for the both, either you are a diabetic patient as well as the non-diabetic patients. And what we know that with the new class of ARNI as one of the mainstay of the treatment for heart failure, even on top of sacubitril valsartan, you have the beneficial effect of adding up of the empagliflozin shown beneficial effect. The key secondary benefits was adjudicated total hospitalization for heart failure, also shown clearly about relative reduction of 30%, is statistically very significant. And another key secondary endpoint, the eGFR slope, which is worsening of the kidney if you on the placebo with the standard of therapy, and that be halted or delayed the progression of the kidney by using empagliflozin. And the composite renal endpoint, end-stage kidney disease or sustained profound decrease in eGFR, was quite remarkably shown of 50% relative reduction with absolute reduction about 1.5%. And one of the key safety issue was whether hypotension, hypovolemia, and hypoglycemia, which was not shown any safety concern, and no issue of ketoacidosis been documented in the trial for the diabetic as well as the non-diabetic patient. So the conclusion that they take home from this, there's a paradigmal shift from the treatment for the CV outcome. From glucocentric approach, we are moving to the cardiocentric approach, the mainstay of reduction in cardiovascular event and mortality. And of course, we need to address the multifactorial intervention, blood pressure, the statin, the weight reduction, and emphasis on the drug that reduce the CV as well as the renal event. And the HbA1c played a role, and especially for the microvascular complication. The second is the shift from the anti-diabetic drugs, the empagliflozin, moved to the drug that reduce CV and the renal events. And the last is the EMPEROR-reduced, clearly shown, where reduction in the CV death or hospitalization for the heart failure, and also the key secondary endpoint, the first and recurrent hospitalization for heart failure, and slowing up of the worsening of the kidney being shown, and there's no safety issues at all. And now for the heart failure, we know these are the foundational drugs, ARNI, ACE, MRA, and beta blocker. Now if the SGLT2 inhibitor, whether you are diabetic or not diabetic, probably is going to be another foundational or landmark for our treatment for the heart failure. With that, thank you very much.